So if there are no further questions, we go to practical applications. David, your computer is working again. Everything fine?
Someone else's computer is working. Okay, so we're going to talk about rib-based anchors in distraction-based implants. So let's take a survey of people in the room who do this. I want to know who does spine implants at the top of a distraction-based construct versus ribs. So who's a spiner here? Raise their hands. Okay, and who's a ribber here? Okay, so ribbers are a little bit in the minority, but at the end of this talk, you're going to be in the majority. So we're going to talk about rib-based distraction. And what we're talking about here is big rib anchors. We're not talking about these little wimpy 3.5 millimeter Vector things that we know love to pull through ribs. There's now some hooks that are designed, although not FDA approved, and they're not really designed this way, but they're designed to be put on a rib. They may have a spike, or they may have big, thick areas to put on a rib, and I believe, though I don't have data to prove it, that they probably pull through ribs a little bit less than those thin Vector cradles. So we're going to talk a little bit about theoretical advantages. So if you have rib anchors instead of spine anchors, you definitely avoid a proximal fusion. That's just true. You're not dissecting the spine. I'm going to propose to you it's lower profile. It's a less rigid system that is associated with less rod breakage. That's a good study that's been concluded. There's a safer failure mode. When a rib hook pops out, nothing's hurt. When a pedicle screw pops out, it has, in cases, injured the spinal cord. And there's a better moment arm. And I'll show you some cases where you really want to be off to the side to maximize shoulder tilt. Now, no difference between rib and spine. It looks like pull-out strength, PJK, and failure rates pretty similar. I could not find any clear advantages to spine implants in the literature. So we're dealing with kids who are nutritionally depleted. And I think we've all had some kids with spine-based implants at the top of growing rods where you could almost read the serial number before the metal erodes through the skin. So let's talk about the technique of putting in a hook. One is we make a midline incision because we're planning that eventually this patient will need a spinal fusion. So we want to have a midline skin incision. Then superficially, just go off to the side, and we plan on putting the hook there. And once you go off to the side, you just stick your finger through the muscle. A decade ago or so, I used to take pride in picking up this muscle layer and picking up this muscle layer and acting like a plastic surgeon. You don't really need to do that. All you need to do is reach over, feel the transverse process, just wiggle your finger on down there, bang, you're right on the rib, and put the hook in. And as you can see, this is very low profile. If you have a pedicle screw up here, this is a little bit lower profile, and you have the scapula right next to it to minimize profile of the metal. So again, we make a midline incision. We're not touching the spine at all, except maybe with your finger. You just feel that transverse process. Boom, you feel it pop off to the side, and right there is where you want to put the hook. If you put the hook way out to the side, you've probably all seen these ribs that kind of go up. If you put it right next to the transverse process, the hook tends to stay there, and it's a little bit stronger. So here's a video. You just stick your finger there. You push through the muscle. You feel the spine. Push the hook there and rotate it right in. So this is an example using a rib hook with a hook holder. I'm going to play this one more time. And I hardly ever use a bovie at this stage. You just move with your finger and pop the hook right into place. And then there's enough muscle there that it holds it. I don't really hold my finger there. This skeleton doesn't have too much muscle on it. Now, when you're doing this at the very top, if you use a hook holder, you hit the patient in the head. So here's a hook impactor. So the key thing from a technical standpoint is you want to get the hook all the way down, and then you just rotate it. And you do have to push towards the head fairly hard sometimes to pop it in there and get through the soft tissue. And ideally what we want to do is be subperiosteal. You're pushing right along bone. Somehow that neurovascular bundle just never seems to be a problem. I don't know why, but it's never a problem. We're not in the chest. We're intentionally not putting in a chest tube. At the very end, though, fill it up with water, ask for a Valsalva, and it's very, very rare that air bubbles up. If it does, put in a chest tube, but I probably haven't had that in 5 or 10 years. You know, these hooks generally do not require a chest tube. Now, there are people who believe that you must put a claw around the rib. My personal experience is if you're really pushing up with that, I've never once seen a rib go, hey, let's jump out the top. It just doesn't seem to do it. If you have big enough hooks and you're pushing up, the ribs don't jump out the top. Though I know there are people in this room who are good friends of mine that prefer that. I think it looks better on a slide, there's no question. Anyone want to comment on this?
I think for kyphosis at the top, you often find that the same slide that you showed, that the bottommost of your 6 hooks stay on, but as the spine PJKs, my sense is that having the claw up there makes it easier, and also those are the cases that it's most difficult to capture your downgoing top part of the
That's a fair point. I wonder if we could study that. Okay, so poor soft tissue coverage. That's a time when I would tend to use one rod. So if you have a really, really skinny kid, the convex side of the curve tends to be really high, and it tends to be hard to cover the metal, particularly with the magic rods that are pretty big. So this is a case that you may want to use a single rod. And note how close these ribs are together here and how open they are there. Jack Flynn speaks of this as portable traction. I love that idea. And note that there is no thoracotomy. In my mind, unless you have like 5 ribs fused, you don't want to cut through ribs. You want to have nice spaces between all the ribs instead of lots of space between 2. So in 2018, my preferred construct for distraction-based growing rods are either magnetic controlled ones or mechanical. We're not going to get into that. And at least, if we can, like Lindsay said, 6 hooks at the top with dual rods. In kids who are super thin, we might want to start off with a single rod and then maybe over time move to a double rod, because the studies have shown us that double rods lead to more growth than single rods. And I know it's debatable whether you can use this technique of rib hooks on kyphosis or not. I think you can. I routinely do. And the studies have concluded that spine-based and rib-based seem to pull out at about the same rate. And it's a truism. Almost never do you want to fuse to the top, or do you want to put a cradle or a hook in the top rib. And the reason why is because the brachial plexus goes just above the top rib. And I had one patient where I had a hook on the second rib, and we stretched her out a whole bunch and made her spine really straight, and she went home and her arm kept hurting and hurting. And the MEPs were normal. And I was on the phone with the mom. I said, wait, have her put her arm above her head. She goes, yeah, the pain went away. She put her arm down. Ow, it hurt again. So the lesson we learned from that is when we're pushing up on ribs, we have the arms at the side, so we're monitoring with the arms at the side. When we put that patient back to sleep, arms are up, MEPs are great. Arms are down, MEPs are not so great. So arm positioning can matter. And another paper that has shown that the number of anchors is what determines the pullout rate. So the pullout rate is much less if you have 5 or 6 anchors at the top, and this is whether it's hooks on ribs, hooks on the spine, or pedicle screws of the spine. It's the number of hooks that resist pullout, and as Lindsay showed, maybe if you have 6 of them and 2 pull out, who cares? You got 4 other good ones. And another thing that decreases the risk of pullout at the top is if you've gone high enough. So think of the upper end vertebrae of the sagittal cob as being the most tilted vertebrae. We want to make certain that our anchor is at or above the upper end vertebrae to minimize pullout. It would also decrease PJK. Okay, so I love showing things that I do wrong. So I did something wrong here. I'm going to see if anyone could figure it out. If you can't, I'll give you a hint. Any clues here? Come on, you're shaking your head. Speak up. I've never heard you be quiet. You can't hear someone be quiet.
I don't like where your actuator's position. I think that's a little high.
So you're telling me I put the actuator too high? You're telling me that the thoracolumbar junction is straight, and that's where we should put the straight actuator. So I know that. We're even doing a study on this, and I still did it, because sometimes you put the hooks in there, you put the thing, and then you distract. I didn't think it would distract that much. If I was smarter, I would have distracted from here and pushed the actuator down. So as predicted, I did a totally boneheaded move. I put the actuator too high, boom, it popped out. So we went back, we revised it, put the actuator lower, bent in a little bit more kyphosis, and everything's happy. She's a few years out now, it didn't pop out again. So the next thing is, so what do you do when the hook pops through the rib? It's going to happen to all of us. You just go back in and put the hook on the same rib. So ribs heal quickly. By the time it pops out and you get the kid back to the OR, it's probably not only healed, but there's probably even more bone there. So you want to do is make sure you have one of the systems that's made to put on ribs because they have big hooks. The regular lamina hooks won't always fit over a broken rib with its hypertrophied bone. And once that rib breaks and it's hypertrophied and big, it is an awesome anchor. You want to take advantage of that. Okay, special circumstances. So here's a 3-year-old girl who's 4 hemi vertebrae opposite a unilateral bar. Clinically, her ear was touching her shoulder when I met her. Any suggestions of what we should do here? Well, since we're talking about distraction-based growing rods with rib hooks, let's do that. And so this is what we did. And here's 5 years out. You could see that the hook is eroding through the rib, and it looks the exact same when she's 15. And the way that God designs unilateral bars is she puts a really thick rib right at the top. So this is the one time that you can put a hook at the very top rib, and you're generally not going to push it up enough to hit the brachial plexus. And this is what the girl looks like at age 15. So she came with her, stop that. She came with her ear on her shoulder, and now, even though she has some scoliosis one way and the other way, you can't tell from looking at her. So I'd make the argument that was a very safe way to get a good outcome, and we didn't need to do something heroic like a VCR there. And this may be the last one. So another time you could use rib hooks in a special situation is if you have a hemi vertebrae, you take out the hemi vertebrae. If you try closing that down with pedicle screws, often the screws would plow. So in the thoracic region, you have the luxury of putting a rib hook above or below, doing all the compression on your ribs, and then placing the screws, and that would save the screws from plowing. And you could either leave that hook in for a while or not, either way. That's it. Questions, Carol?
Thanks, David. Questions from the floor or remarks from the ripper and non-rippers?
Hey, Dave, really enjoyed the talk, especially that last case with the cervico-thoracic curvature. Dave, it appeared, I mean, that's a phenomenal result on that child. But it appears that you went short of the end vertebrae and still attained that result. Is that true? Am I seeing that correctly? That your distraction was short of the end?
I'm not sure what you're asking.
Meaning, it looks like that the cob goes up into the cervical spine, probably C5.
Yeah, I think I went up to the highest hemi vertebrae. So whatever the highest hemi vertebrae was, I put in a screw there.
Got it. And then you distracted off of the T1 rib. Yeah.
Put in screws there, put in little osteotomies. You can't compress much because there's a unilateral bar. Compress as much as you can here, distract as much as you can there. I think in her I distracted in total 3 times. When the kids are like this and you don't have a lot of space, there's not a lot of distraction that's going to happen, so we don't need to distract that often.
I think Scott had a question.
Great talk, Dave. I appreciate it. I do quite a few rib hooks myself. So 2 questions. Number 1 is going back on revisions of these in the ribs, you pull through and you get a large bar between 2 ribs that you want to use again. First of all, how do you tackle that question when you have several of them fused? Second of all, there's a lot of people who argue that putting rib hooks on there changes the chest function. It stiffens the chest. How do you?
Okay, so first question, when you're going back to put in hooks and hooks are pulled out, there may be fused ribs. One thing is, because there's so much bone, 1 hook may be enough, or you could just go in with a burr, cut a hole right in the middle of the rib mass, and put in another hook. So it's pretty easy, I think, to get hooks into bone. If there's a lot of bone, we could put hooks in them. And the second question, I'd like to hear what Greg has to say about if you put hooks on the ribs, are you decreasing function of breathing? So remember, in an adult, 2/3 of the air comes in and out from the diaphragm moving up and down, and 1/3 comes from the ribs moving up and down. Now, my belief is if you're right absolutely next to the transverse process, there's probably not a whole bunch of movement there anyways, and I think that maybe the amount of straightening we're doing to the spine is going to help pulmonary function, but I'd certainly like to hear what Laurel and Greg have to say about it.
Well, Greg can correct me on this, but the upper ribs, and I don't know if this is why, but you could theorize that the upper ribs really don't bucket handle the same way. They move sort of with a posterior anchor in front and back, whereas the lower ribs that aren't attached to the sternum, I think, are the ones that come out, and maybe that's partly protective. But
Greg's nodding yes. He doesn't have the microphone to do that. But, yeah, it makes a lot of sense.
I don't think I'd get dogmatic about it. I'm not sure that one versus the other is going to make a big difference on the top part of the chest like you're all talking about. It's primarily when you use the muscles up here used to lift the chest up and not out, as you're all describing. So it's a fairly safe region in terms of stiffness. I think as you produce distraction, though, I'm not so sure that you're distracting from above and below, and so it's not just the upper portion you have to think about. So I'm not sure you can say, oh, the lower half is fine. I don't want to go that far.
So if you're distracting on the spine or the ribs, it would probably have the same effect in the middle of the spine, right?
Maybe. I mean, we just don't know.
Yeah, just don't know. Fair.
Do you know why upper thoracic fusions seem to have a bigger impact on pulmonary function long-term?
John, I had an answer for that a couple nights ago in my dreams. And I've forgotten what it was. If when I think about it again, I'll tell you, okay?
Perfect.
David, we had a little project some years ago with finite element modeling where we looked at a new implant combining hook fixation with the pedicle hook. Have you tried that out or thought about it, of combining two like traditional ways of fix? Yeah, because as you say, we are very close to the transverse process. We are very close to the facet joint. So you could also combine it or even come from above. Have you?
I think that's a good technique. If the kids are really, really small and have weak bone and thin ribs, combining a pedicle screw with a rib hook is the best of all worlds. But I find that very uncommon that that's needed. I find just getting 3 rib hooks seem to be enough most of the time.
Have you seen any impingement of the rib hook to the scapula? Any conflict there? Mainly in myelomeningocele patients who use their scapula, the joints very actively in the wheelchair. We have seen that in some vector patients where the hooks were a little bit more laterally. Have you seen any of those issues clinically in your patients?
Yeah. I don't think I have. There's, of course, the worry that are these hooks going to bother the scapula? And I think when we were doing rib-to-rib fixation in Vector that was really lateral, I did see some kind of annoyance of the scapula. But if these are in the right place, they're not touching the scapula. So I've not seen it be a problem. Now, at the same time, in simple AIS kids, there seems to be periscapular pain after a fusion. So I don't know if that's due to screws or what. Yeah. Any other comments on that?
I have one more comment about your approach to something we've spoken about a lot before, David. I really prefer to make that J incision in line with the rhomboids lifted up as a full thickness flap and then go right down to the ribs. And I understand what you're saying about placing the hook, but the thing is, by the time you place 3 hooks and then lay a rod in, you're going through a fair amount of muscle that you're going to need to approach again. So can you tell me your thoughts and experience about when you go back after you've basically done a whole longitudinal split of the rhomboid in order to get the rod in 3 hooks?
Yeah, so when the hooks get placed in, let's say they have a hole right here, then the rod slides in from the bottom. I'm not doing a longitudinal incision. I'm not splitting all
Under the muscle or above the muscle?
After the cocktails, probably.
And one thing you don't want to do is go under the rib because the heart's there. And apparently, dozens of years ago, a patient didn't make it after a ride like that.
Okay, thanks, David. So we move.